So, good afternoon. Welcome to the 10 Commandments of Critical Care. So what this is, it's 10 cases, and each case has a teaching point. And we'll get a chance to see if anybody can quickly come up with what the teaching point's going to be. Some of you have seen this talk before, so it will be not fair for you to participate. So the first case is a 54-year-old female with severe acute respiratory symptoms due to asthma, admitted to the ICU. These are all real cases, by the way, and either I was personally involved or colleagues of mine. And sometimes we came in on the tail end because trainees were involved until we got on board. Despite aggressive inhaled bronchodilators and intravenous steroids, her condition worsens, altered mental status develops, the decision to intubate the patient is made. Patient is obese, and it is, in quotes, difficult to visualize the larynx despite administration of IV midazolam. The decision is made to give IV succinylcholine. Subsequent intubation is difficult. The patient continues to deteriorate and arrest. Resuscitation is unsuccessful. Now, there's some ethical considerations here, and I was not the one to do this, but the attending took several post-mortem x-rays. This was a post-mortem AP. Do you see anything? I'll just let you look at that a second. And then took a lateral. Okay. And the commandment is thou shalt not intubate without good visualization of the glottic opening, with rare exceptions. Sometimes it's the only alternative, but when it isn't the only alternative, it's not good. Not good. Let me see if I have pictures. So what do you see on this film? So lots of starburst subcutaneous emphysema. What else?
Endotracheal tube is actually at the neck. Is that what I'm saying?
So the endotracheal tube is at the neck, and also in this film that's not severely rotated, it's definitely off center.
Yeah.
You see it here?
On the chest wall?
Yes, anterior to the sternum. So this is an example. This is the ultimate example of passing an endotracheal tube without good visualization of the glottic opening. And I wish I could say that this is the view that most of us get. I think this is actually an autopsy specimen. You rarely get a view quite this good. And, as you know, this is not a review of the literature. There's debate about whether a glide scope gives you a better view than direct vision. And probably there's some circumstances when one is better and some when the other. This is a real glide scope vision, nice grade 1 view. So let's move on to the next case. Any questions or comments about that one?
What would be your rare exception that you had at the asterisks?
I've intubated before when I just saw the base of the arytenoids, and you felt like that was the best risk-benefit thing to do for your patient. But you always need to be very quick to be willing to pull the tube out if things don't look like they're going in the right direction. And the other faculty here, feel free to comment.
Well, the only thing I'll say is that if there is the instance where you can't visualize the airway, don't forget that we do have adjuncts like bougie. Bougie gives you the tactile feel. So
In fact, bougie would probably be a safer thing to do if you just had a low view, because you'd have more direct visual evidence that you're actually going in instead of losing a little bit of blind spot at the end with the endotracheal tube.
yeah, and even when you don't see that, in the cases where the tube needs to go in, you don't see anything, the bougie, not always, but will often give you the rings. So you feel the rings, or you'll get distal hang up when you get to the right main stem versus the esophagus where you're all the way through. So if you can't see it and the tube has to go in, that's another feedback mechanism about using your eyes that you know that you're in the right place.
Second case, a 32-year-old male has been seen twice in the emergency department and discharged with the diagnosis of painful exudative pharyngitis. On the first visit, he received antibiotics. On the second visit, steroids were added. Obviously, no indication of steroids for exudative pharyngitis, but these are all real cases. Returns to the ED with a chief complaint of chest pain. He's hypotensive. Breath sounds are equal and normal bilaterally. Physical appearance and EKG are shown. This is a view of his neck. This is his EKG. Commandment, you can make up your own commandment. If you think you know what the diagnosis might be, you can just make up a commandment. It might not be the exact way that mine is stated. Thou shalt remember that common benign diagnoses can turn malignant. And what's the malignant diagnosis here?
Ludwig's.
Ludwig's, it definitely is Ludwig's, but it's even beyond Ludwig's.
Mediastinal extension.
So mediastinal extension with mediastinitis producing pericarditis. Great case, isn't it? This guy did good because he's young. So here's the neck that you can see the redness is extending up from something that started in the pharynx, and you can see inflammation of the skin and soft tissue. And here's the EKG, pretty classic for pericarditis, diffuse ST segment elevation or diffuse PR depression. What's the verdict these days? What's the most correct?
What's that?
PR depression or ST elevation?
It's both.
Okay.
Yeah.
And this was his CT, and you can see here you've lost all the distinct tissue planes. Normally you can see well-defined tissue planes with thin lines in the anterior mediastinum, and here they're just very indistinct due to the inflammation. Negative pressure wound therapy for Ludwig's angina case series, used as an adjunct to antibiotics and surgical debridement. This is a true surgical emergency. This is a source control problem. This person needs OR debridement, drainage, possibly 2 or 3 before a wound vac would be applied. And negative pressure wound therapy is just another name for wound vac. Third case, 55-year-old man is admitted to the ICU from the ED with elevated temperature, increased white blood cell count, and swollen right arm. Diagnosed as cellulitis. Patient is profoundly tachycardic with hypotension, decreased platelets, and elevated creatinine. Antibiotics and volume resuscitation are initiated. Blood cultures, antibiotics, lactate, 30 mLs per kg, crystalloid, balanced crystalloid. This is what his arm looked like. upper arm. Commandment,
Thou shalt
I
not
just
sleep
compartment
syndrome.
not sleep on.
Compartment syndrome or
Yeah.
necrotizing fasciitis.
Yeah. The only two times that I've ever in my career have ever gone up the chain of command, both times were calling the chief of surgery, and both times were source control issues in the middle of the night, and both were necrotizing fasciitis. You can't sleep on these patients. Thou shalt not underestimate the extent of a skin infection. This is classic. This is the purplish blisters due to knocking off the arterial feeders that are supplying blood to the dermis, so you get necrosis. Bacteria grow up in them. You can actually make the diagnosis of necrotizing fasciitis in some patients just by doing a small aspirate at the base of one of these blisters and gram stain. You can see denudation. Classically, the patient loses feeling in the dermis because the nerves are out. Oops. Oh. So this is this particular patient's debridement. He had 3 surgical procedures, and this was in the day before wound vacs, but he actually did quite well with his reconstructive and plastic surgery. So necrotizing fasciitis, type 1 is mixed aerobes and anaerobes. That's the one that gives you the gas from E. coli and anaerobes. Then monomicrobial beta hemolytic streptococcus is billed by the media as what? Flesh-eating bacteria. And then Staph aureus can do the same thing. You can see toxic shock syndrome associated with necrotizing fasciitis, where it has some of the characteristics of toxic shock. And Vibrio vulnificans, I think we had one here recently. It's the risk factors. I knew it wasn't Paul. Just gonna take a message on that. What are the risk factors for Vibrio vulnificans? Cirrhosis.
Hemochromatosis.
Probably liver disease. I would think that any severe liver disease.
Shellfish.
Yeah. Hello. I'm good.
Just
I'm in the middle of a lecture. Can I call you back?
But the other end of the spectrum, some patients present with what they call labellum deferens.
No, it's not a problem. Have a good day.
I don't know. I just saw this thing. They're like, that must be so painful. They're like, no, I feel fine, and that's because of the ischemia of all the nerves. So that's already, already down to the fascial layer. So that's also another concern.
Yeah. You have anesthesia at the dermal surface. Yeah, we used to see when I was in Houston. It's right there on the inlet coming up from Galveston. A lot of shellfish and a lot of cirrhosis. So those two came together. This is a pic of Vibrio vulnificans with these classic purplish blood-filled bullae. How'd the patient do here?
It will discharge.
Lost all his extremities.
Yeah, lost his extremities.
Yeah.
Actually got a nice follow-up picture of him in rehab, decannulated from the straight and
So this is what?
Fournier's.
This is Fournier's gangrene, which is a type of necrotizing fasciitis, and it's the mixed floor of the type 1. Again, radical debridement is needed. This was a hemorrhagic bullae on the bottom of the foot of an insulin-dependent diabetic patient, and insulin-dependent diabetics are at risk for necrotizing fasciitis. And this is a nice demonstration of being able to make the diagnosis with just a plain film of the extremities. And if you're not used to picking up type 1 necrotizing fasciitis, you're looking for air, and it's normal when you look at soft tissue to see those linear streaks of air, and that's just separation in the fascial planes. But it's this bubbly type air that you see that looks sort of like little beads of air that's diagnostic. So diagnosis can be made with plain soft tissue if it's E. coli or anaerobes. CT scan can suggest the diagnosis, but obviously not make it. MRI can suggest it, but not make it. It can strongly suggest it, can almost make it. But exploration is the true diagnosis. And we've had some patients here where I've called the surgeon to the bedside, and it's just straight to the OR. You don't even need any imaging. You just look at the patient and you look at the scan and stuff, and it's time to go to the OR. There have been laboratory risk indicators for necrotizing fasciitis. I haven't used them. You can tell this is an English one because the creatinine is in micromoles per liter, and glucose as well. Fourth case, a 27-year-old male presents to the ED brought by family with complaints of severe weakness. Physical exam reveals muscle weakness in both upper and lower extremities. Respirations are rapid and shallow. Blood pressure is 150/100. Pulse is 135. And the blood gases are pH of 7.18, PaCO2 of 50, and PaO2 150. So what's the acid-base diagnosis or diagnoses here? So there's a respiratory acidosis because the PCO2 is elevated, and you can always make a positive statement with a blood gas. If you're thinking about, if someone's grilling you, just always go straight to the PCO2 and make a statement. There is a respiratory acidosis. There is a respiratory alkalosis. I don't see any, respiratory component here, either primary or compensatory. But then when you look at a 10 rise, you expect a 0.08 drop with acute respiratory acidosis. So you would expect a 732, and it's 718. So this is a combined respiratory and metabolic acidosis. And here's the electrolytes. Bicarb 17, potassium is 1.6. Mental status is normal. Patient appears to be in mild to moderate respiratory distress. The decision is made to intubate and mechanically ventilate. What's the commandment?
Try to match the acidosis when putting someone on ventilator.
You should try to do what?
To match up their acidosis. So don't put them on a low respiratory rate and not compensate for their metabolic acidosis. Something like that.
It's sort of around acid base. My commandment was thou shalt not hyperventilate a patient to death. So the concern here would be the effect of changing pH on potassium, although this particular case may be a little more controversial when I first started using this case, because now there's considerable discussion about what moves potassium intracellularly and extracellularly. Is it pH driven or is it more bicarb driven? And it's become more complicated over the years, but the point is that you need to be aware of shifts in potassium related to acid base. What else can we say about this metabolic acidosis?
Non-anion gap.
So it's a non-anion gap metabolic acidosis with a very low potassium. So what should that make you think of?
RTA.
Yeah, so renal tubular acidosis. This is a differential of non-anion gap metabolic acidosis. Hyperalimentation, acetazolamide, renal tubular acidosis, diarrhea, retrosigmoid fistula, pancreatic fistula, and I guess we need to figure out a place to put normal saline resuscitation in here as well. This is why I didn't go into renal, but this patient had RTA, had type 1 renal tubular acidosis. We'll talk about why in just a sec. Impaired hydrogen ion secretion with urine pH greater than 5.5, hypokalemia. There's a proximal RTA type 2, impaired bicarb reabsorption, high urine pH initially, later less than 5.5, and hypokalemia. I think this was type 1, but I should have looked it up before. I can't. It's either type 1 or type 2. Some of you may know when you see the cause. This was a chronic toluene abuser. And with chronic toluene abuse, you get severe renal tubular acidosis and hypokalemia. This guy would come home every day from work and would do what's called huffing. You know, there are two types of toluene abusers. There's huffers and there are baggers, and both are getting the fumes from the toluene. He was a huffer. He would drink a Coke, maybe not all of it, took a beer opener, put 2 beer opener holes, one on each side, and would spray toluene into the can. The spray paint would spray, put spray paint, and then just huff it, you know, drag the air in from one hole, and then he'd take it out the other. And he told us that the metallic colors have the highest toluene content. So he was quite the connoisseur of toluene. He's actually a nice guy. This is a bagger. You know, baggers will take a bag and spray the paint in it and then put their face in the bag and breathe it out and then put more in. So when I was growing up, unlike those of you in the room, we could go into stores and we could buy airplane cement for, you know, putting model airplanes and boats and stuff together. You could just walk in and buy it. You know, underage you could buy it, and now it's all locked up in cabinets. Fifth case, a 64-year-old female who lives alone is brought to the emergency department by family members because of a change in mentation. She's oriented to person in place, vital signs are normal, and she is afebrile. Laboratory tests, including electrolytes and urine toxicology screen, are obtained. Serum chemistries are reported as sodium of 108. Potassium 49, chloride 76, bicarb 24. She's admitted to the ICU. What's the commandment?
Thou shalt not overcorrect hyponatremia.
Yeah. Thou shalt correct chronic hyponatremia slowly, which is the exact same thing you said. And how do you know this is chronic hyponatremia?
She's awake and talking.
Yeah, so she's oriented ×2 with the sodium of 108. So she's got idioosmoles that have backfilled into her extracellular space. Rate of correction of severe hyponatremia to avoid osmotic demyelination syndrome. 5% increase in serum sodium substantially reduces brain edema, and the three potentially life-threatening hypokalemia issues that can develop are cerebral edema, pulmonary edema, and status epilepticus. Those are the ones that need to be aggressively treated. The rest of them, you're better off doing the lightest treatment possible. 4 to 6 milliequivalent per liter increase in serum sodium controls seizures, and life-threatening cerebral edema. That should be your first day target, and always prescribe 3% saline with time parameters. You know, never have a standing order for 3% saline. And there's some nice formulas that you can use to tell you how much, if you want to move the sodium this much, and you're going to use normal saline or hypertonic saline, what's your current sodium and what's your target, and how much of that fluid you would give to get there. It does make one assumption. It doesn't factor in what the sodium is going to be in the urine. So it assumes a closed compartment and doesn't account for the sodium water relationship that's going to be leaving the kidneys during that time period. Most cases of osmotic demyelination syndrome are when you correct the sodium greater than 12 milliequivalents per liter in the first 24 hours. Osmotic demyelination syndrome was originally called
Central pontine myelinosis.
Yeah, central pontine myelinolysis. Why did they change the name?
Hard to say.
It occurs in places other than central ponds. So that was a good reason to think about changing the name. It's a cute little figure. As far as osmotic demyelination, it's when you rapid onset of acute hypernatremia, where you're driving up the osmolarity in the extracellular fluid, or rapid correction of chronic hyponatremia when you're driving up the sodium and not giving enough time for the idioosmoles to leave the extracellular space. And with cerebral edema, rapid onset of acute hyponatremia and rapid correction of chronic hypernatremia. The fact that most patients that have slow development of hyponatremia don't have major life-threatening problems. They don't have cerebral edema, they don't have pulmonary edema, and they typically don't have seizures. So anytime you're seeing those, there probably is likely to be some acute component involved. When you use hypertonic saline with life-threatening manifestations of hyponatremia and what I call scary low serum sodiums, and that's, I'm sure, varies from individual to individual. Typically, free water restriction will start moving the sodium up, and if free water restriction doesn't, then just normal saline will. And if normal saline doesn't, sometimes you can just add a loop diuretic to the saline, or you can use hypertonic saline. Increased risk, alcoholics, malnourished, males, liver disease, and long-term diuretic usage. got an oldie but goodie for you here. This is something that would not happen in 2019, but this story is just straight out, absolutely reproduced without any change in what happened. This would have been, I would guess, 1986 was when this occurred, but it's still a nice example of the point I wanted to make. A 65-year-old male with coronary artery disease presents to a teaching hospital emergency department with new onset AFib, rapid ventricular response, vital signs, blood pressure soft, tachycardic, a little tachypnic, afebrile, and heart monitors in place. After unsuccessful attempts to establish a peripheral IV access, a central line is placed. Gets 0.5 dig, slow IV push, which is, it's a good choice when you have a soft blood pressure, but you're not hypotensive. 30 minutes later, the BP is 118/80. Ventricular response rate's 100. The patient remains in the overcrowded, busy county emergency department awaiting availability of an ICU bed, and that hasn't changed. Serum potassium returns revealing a value of 2.9. The extern, a fourth-year medical student, is instructed by the resident to give 40 milliequivalents of KCl. And in 1986, doctors and medical students in county emergency departments wasn't unusual for them to actually give meds. Now the intent here was to give PO potassium, but the student got 40 milliequivalents of IV potassium, and the commandment is thou shalt supervise medical students. This is, I used to collect cases because I used to give a lot of case-based talks, and this is what his rhythm strip did that I captured after we had resuscitated him. But he was luckily sitting on the front row of the county emergency department in Houston, where everyone was walking by. It was a busy transit, so when he started going south, people noticed. But you can see that he went from peak T waves to sine wave to flatline. And he got intubated, he got CPR. It's a little different in that his potassium was directly into his right ventricular outflow tract, more so than producing a huge rise. This should have been a case report, especially with pretty pictures like this. But here's another case also from the county emergency department in Houston. This was a guy that had missed his dialysis for a while. That's the rhythm strip when he first got put on the monitor and got put on the gurney in the county emergency department. And then here's the rhythm strip later on when he still hadn't been dialyzed. And you can see he went from peak waves, T waves, to sine waves. The hyperkalemia cocktail, first published in 1954 in JAMA. The 50% dextrose, insulin, and sodium bicarb. Treatment of life-threatening hyperkalemia, probably the most important, I think, is calcium because it stabilizes the membranes immediately. Glucose and insulin also acts very quickly to lower the potassium. And inhaled beta agonists also act very quickly. So these are your three quick-acting things to do that are not controversial. I think everyone would agree that these are good things to do. The rest of the group are a little controversial or don't give you a big bang for your buck, except for dialysis, I guess, does. I think my reading of the literature is that bicarbonate works if the serum bicarb is decreased. There's a question whether it works if the serum bicarb is not decreased. Getting back to the point I made earlier about pH versus bicarb. Furosemide works, but again, it does push potassium out the kidney, but 90% of potassium is eliminated by the kidney. It's not used that much. K-oxalate, pretty worthless for acute hyperkalemia, and they're better agents now. And dialysis does work, but takes a while to get it set up. These are just the doses. Barotrauma is a calcium polymer that is less likely to produce complications than K-oxalate and would probably be preferred. Any comments on that case? Jason, Emily?
All I would say is, we can EKG talk to you guys later, but if you go back to that second strip that you had, that tally at the top, I mean, as emergency physicians, as intensivists, we need to recognize that as hyperkalemia before we have labs to support it and treat it empirically. Because even with a gas with light, sometimes that takes too long to come back. So it's just one of those rhythms that will burn into your brain. You lost your P wave already, you have prolongation of your QRS, so you know, beyond a peak T, once you have a rhythm with no P wave or a prolonged PR interval or a prolonged QRS, you have to be very concerned and at least have it on your differential diagnosis.
And I'll also throw out there may be some rumblings around the way of giving calcium in the setting of someone who's on or has received digoxin.
Right, exactly.
For the theoretical Stoneheart precipitation, but I think that's been largely disproven as being a true entity, but I've still seen that come up on board review material as a relative contraindication.
The only thing I have left is from an ABIM board standpoint, still a very popular question. It would be side effect for K-oxalate, which would be necrosis, right? That is a classic exam question. There's not a whole lot of pharmacology that you guys would be responsible for, but that one is.
That's a good point, Jason. And if your hospital has the newer binders, it certainly would be no reason to use K-oxalate. What do we have here?
Beltesa.
Both.
Yeah,
Both.
But no, actually, I think K-oxalate is it all formula.
They
took it off.
Yeah,
once we did
That would
the
make
test.
sense if I was on Cooper risk management.
Yeah.
I mean, it's rare, but it's not worth even taking the chance. A little bit of poetic license here. I'd be curious. I'm always interested in, particularly with a lot of emergency medicine influence on our division. You respond to assistant code of a 48-year-old patient who's found unresponsive. Patient has received one counter shock, and the ECG tracing is being interpreted as either fine VFib or asystole with variable baseline. Another shock is about to occur. Commandment. Yeah, this case was, we used to have the life packs where it was pretty easy you could set not have the paddles, there was a paddle and a lead, and if you were using the paddles to see what your rhythm was and you had it on the chest leads, or vice versa, you would get this flat line looking fine VFib looking picture. And that's what happened in this case, and it was a problem for us. That's happened several times. I would think that modern technology has fixed that. But I'm also reminded that when we had a patient with hyperkalemia, what's a lot quicker than getting potassiums, unless you have potassiums on a blood gas, but even then they're slow. We used to mark a spot on the chest and we used to have the metal suction cups that you put on for V leads, and then they're rubber, but draw a circle around it so you could keep putting that one V lead in the same spot in order to track your T wave. And you could see your peak T wave decreasing over time with treatment. So that makes the point. Also, anytime someone seizes and goes down, probably the first thing you should do, even before making sure you're protecting them, is feel for carotid pulse, because I've seen numerous patients that seized as the first clinical manifestation of VTAC or VFib from just brain hypoperfusion. Pulse check 5 to 10 seconds after shock, 2 minutes CPR before pulse check. 23-year-old asthmatic is admitted to the ICU with status asthmaticus. Despite maximum therapy, the patient's distress worsens. The patient is intubated. A supine chest radiograph was taken shortly prior to intubation and is shown. So this patient was actually, the decision to intubate this patient was made simultaneously with the plate being placed beneath the patient for the x-ray. And the patient was intubated before the x-ray came back, but it produced an interesting series of chest radiographs. This is the initial film. I'll let you look at that just for a second. Commandment.
So for this being a supine x-ray, those look like a deep sulci.
So you think this is bilateral pneumothorax?
With maybe some pneumomediastinum as well.
Isn't that pneumopericardium?
Well, anytime you think there's pneumopericardium, it's almost always pneumomediastinum. So that's one thing to always remember, that pneumopericardium is such a rare entity. The most cases are when someone's been putting air in the pericardium for some procedure. So this is pneumomediastinum, and it is bilateral pneumothoraces. And you can see a little flattening of that diaphragm on the left. Thou shalt recognize subtle signs of pneumothorax on supine chest radiograph. Now, this was not as subtle, but Paul, that was a really nice pickup on that. This is the x-ray that was taken immediately after intubation. So this is a bilateral tension pneumothorax.
Had blood pressure with that chest x-ray?
It still did have a blood pressure, but wouldn't you have loved to? Can you imagine the case report if someone had whipped a quick echo probe on this patient? What that heart would have looked like.
Yeah.
So this is, it should always be embarrassing and almost malpractice if you have a unilateral tension hemothorax causing hemodynamic changes on an x-ray, because you really don't want those on an x-ray. You want to be able to make the diagnosis without the x-ray. Not as critical with this patient because this was bilateral, this was bad luck, and we rely a lot on asymmetry to suspect tension pneumothorax. This is what it looked like after 2 chest tubes. But the guy, obviously, the first thing would be bilateral decompression, thoracotomy, with
Needle decompression.
needle decompression, needle thora, whatever. So when someone is laying flat, the air rises to the highest part of the chest, which is over the diaphragms. And instead of seeing the classic visceral pleural line, all of our brains are trained to recognize pneumothorax based on a white line with black on the outside, black on the inside, and with little vessels on the inside. But when it's up here, you don't see that. All you see is relative radiolucency above the diaphragms, which you see in this case, and the pneumomediastinum. And y'all have heard me say this so many times, but I'm gonna say it again. When you get barotrauma from overinflation or from mechanical ventilation, the pop always occurs into the interstitium. So you pop an alveolus and air enters the interstitium. It doesn't go to the pleural space, it goes back to the mediastinum. And then once it gets to the mediastinum, it typically just rolls right out into the pleural space from the mediastinum on one side. And so you get a pneumothorax, but it didn't go directly into the pleural space. It came back to the mediastinum and then went into the pleural space from the mediastinum, which is why sometimes it can't get to the pleural space, so you'll have just a pneumomediastinum. And you're not going to get a pneumothorax. You might if you get another pop. Or it can go to the pneumomediastinum and go into the subcutaneous tissue. So you can have any combination of pneumomediastinum, pneumothorax, and subcutaneous emphysema in any patient. You can have 1 of 3, 2 of 3, 3 of 3 with barotrauma. This is another deep sulcus sign there on the right.
Can I bring up one clinical
Yeah,
thing?
yeah.
So Taryn and I had a patient, we were called to the PACU last year. A guy was post-op, a bigger guy was post-op from a esophageal, like a paraesophageal hernia repair. And when they do that, they inject CO2 sort of, I think, into the abdomen ideally, but it can sometimes cross the cruor and go into the chest. Well, the thoracic surgeons are always, if they have any hemodynamic instability or hypoxia, they typically just empirically place a chest tube to evacuate the CO2. So we got called to the PACU. This guy was extremely hypoxic. His peak pressures on the ventilator were not very elevated. We got a supine chest X-ray, which radiology, even as well us, read as normal. Couldn't figure out why. I thought he had an intracardiac shunt or something. And we did a bedside ultrasound looking for pneumothorax, didn't see that. Sent him down to CT, a PE study actually, because we thought that could be another reason. I got called, there's no PE, it looks fine. And I put it on lung windows, and they were the 2 largest anterior pneumothoraces I'd ever seen, but they were actually cap pneumothoraces. So we ran down to the PACU and bilaterally decompressed this patient, but it was something I'd never seen. Wow. It was CO2 that was insufflated during the procedure, and they did the whole surgery. Wow. So fortunately the guy survived, but I look back at his X-ray, you cannot see those. There's no deep sulcus. He was a big guy, but the CT, they were huge, and he was hypotensive too. So I felt silly for missing it, but.
I think important for those of you taking your boards, that reported, the sensitivity for an AP chest X-ray for identifying pneumos is as low as 60%. Yeah. So that's why a systematic approach that may, included ultrasound in that case, but hopefully does. You guys should be able to get that up around 92%. And then there's the 8% of
Yeah, you did the ultrasound, but also who
Uh-huh.
GK
was there.
GK did the ultrasound.
I was like,
GK called
you
me
got
from home and he's like, "That's not possible. That patient had pneumothorax because I did the ultrasound." And I'm like, "GK, we missed it. Like we missed it." But yeah, GK did the ultrasound.
Alright, so then, you know, it couldn't have been. That would have been a great ultrasound to have and then prove that, you know, that's why the sensitivity is only
No, we
90%.
missed it. We missed it.
There's one other place that the air can go after it enters the mediastinum. Where's that? You just reminded me. It's the rarest, but I've seen a couple of cases. Yeah. You can get a pneumoperitoneum from barotrauma. I remember the first case I saw, oh my God, so many years ago. You know, it's just a totally benign abdomen in a COPD patient. And, you know, I've seen them go to the operating room and have nothing. I've also seen you just bite the bullet and don't take them to the operating room and they do fine. But that's something to think about if it just doesn't make sense for them to have a perforated viscous. 20-year-old female found at her apartment with depressed level of consciousness. Vital signs are stable. Good respiratory effort, ABG, normally A gradient, mild acute respiratory alkalosis, Kim 7 normal. Tox screen and head CT are unrevealing. There was no response to Narcan. Chest radiograph was obtained in the semi-upright position. No histories available, no family. Rhythm strip reveals sinus tach. Patient is admitted to the ICU and EKG is obtained to screen for QRS prolongation that might support antidepressant overdose. Here's her chest x-ray. Here's her EKG. I guess this wasn't totally HIPAA compliant because it's got her age and sex on it, but
I can block that on the video.
Play some music.
So I've been at Ben Taub for a while now. Was that 1990? Yeah. Commandment.
Was it cold that day?
Yeah, wasn't it?
Did y'all see an Osborne wave? Well, we'll go back. The commandment is, in some circumstances, thou might wear your heart on your right side. So what do you see on this EKG?
The QRS progression is.
So there's no QRS progression on the left side, right? So that's one of two big clues that you're dealing with dextrocardia. The other is an upright QRS in ABR. So a right-sided EKG would give you the type of EKG you would want in this woman.
Chest x-ray was a trick.
It was, wasn't it? But you know that
again, I've heard this.
I've
seen this one a couple of times. I fell for it.
Yeah. Well, you know, so did the residents. So did the residents and the attendings. So the way this unfolded is that what's the first thing you do when you get an EKG that looks like this? You send whoever got it back to put the leads on in the right place. And it came back again looking identical. So the next thing you do is you get a cardiology consult. So the cardiology consultant comes in and says, "This is dextrocardia." I said, "No, it's not dextrocardia, because it's just not, because here." It can't be.
The L is, yeah.
Yeah. So what happened is the radiology tech saw this come out and said, this is a problem. And instead of leaving it flipped and putting the left on the left, they developed it with the heart on where they thought it normally should be, but they told you that this is the left side over here. So that's what they did with this chest X-ray. So that's the way it should have been projected. So this was dextrocardia and not situs invertus. And last case, 33-year-old Latin American male presents to the emergency department with a complaint of "I feel dead." When I was over the county emergency department in Houston, we had a psych ED that was right down the way from the main ED, but patients came through and got medical clearance. Now, sometimes they didn't get medical clearance. Like this particular patient probably didn't need medical clearance. If you show up saying, "I feel dead," and you have a history of psychiatric disorder. He was having auditory hallucinations, decreased appetite and weight loss, on no meds, vital signs stable. And he got cleared to outpatient psychiatry at 10 p.m. At 2 a.m., a call is received from outpatient psychiatry head nurse. Patient is seizing and on the way to the emergency department resuscitation room. Arrives into the ED shock room where he has a good pulse and his oxyhemoglobin sat on high flow oxygen is good. He does, however, appear acrocyanotic and has irregular respiration. So discussion follows as to need for intubation. So there's probably about shock room. There's probably like 6-7 people in there, residents, students, one attending probably, or maybe none, but I think one in this case. So there were some people said we need to intubate this guy, and there were other people that said, you see acrocyanosis after a seizure. Why don't we just watch him? His SATs are okay. Why don't we just get a blood gas? So the people that wanted just to watch and get a blood gas because the vitals were okay and the SATs were okay won out. So that was the path that was taken. Here's his blood gas. So you can see that his SAT was good on 100% face mask oxygen at a 190 PO2, but PCO2 of 187. It also, there's good literature, actually looked like he's being bagged. When you have really high PCO2s, that 0.08 decrease for each 10 rise thing falls apart. There's sort of a logarithmic aspect to it. So now everyone agreed we should intubate this patient. So when the resident went to intubate this patient and took the first look with direct laryngoscopy, everyone around the bedside saw this look of incredible awe on behalf of the resident, and no one could have any idea what it was about, and asked for forceps. And there were no regular forceps. They could only find mosquito forceps. So he got mosquito forceps, and this is what he pulled out, which is when this guy came into the, he got his little gown and his shoes, and when he went off to psych, they put him in a isolation room that was supposed to have nothing in it but a mattress. But someone had let a broom handle get over on the other side of the mattress, and he found it, and he took his shoe off and used the broom handle to put that shoe back into his posterior pharynx, because the broom handle had blood and secretions on it when people tried to figure out how on earth he could have gotten that thing down there. So the finish to this story, before we talk about the commandment, is that the guy looked a lot better. And so the decision to intubate him was rethought. And again, someone said, why don't we get a blood gas? So they did get a blood gas, and it was 266, 41, 728. You can see he's developed a little bit of metabolic acidosis, probably because of the stress and the strain and the seizure. So this is a seizure-induced lactic acidosis. And the commandment is, on some occasions, even if the shoe fits, thou shalt remove it. Thank you. I gave this talk, I gave this talk somewhere in February after the Super Bowl victory, so.
Did they give out those shoes, or those were like as opposed to hospital socks back in 1990?
Yeah,
or what?
everybody got those shoes.
So those were the those weren't just his fancy shoes.
No, these were hospital issue. They were like, stretchy, stretchy, whatever the substance is.
It's unbelievable. This is why I come to this talk. Just for the last case, I was like, never. It's always better every time I hear it.